my computer. Well, good morning, everyone. I'm Larry Boris, Executive Director of the National Association of Worksite Health Centers. I want to welcome you to our monthly webinar on obesity management medications at Worksite Health Centers. This is one of our monthly series of programs for members of the National Association of Worksite Health Centers and their friends and colleagues. We want to always try to keep you up to speed on the latest topics that impact on-site, near-site, mobile, and virtual health centers. And today I'm pleased to have some individuals with us that will guide us through the new landscape of obesity management and medications. First, let me give you a little introduction again for those who may not be familiar with our organization. NAWHC is the nation's only nonprofit association supporting employer and union sponsors of on-site, near-site, mobile, and virtual health centers. We do assist employers and those who sponsor these centers in developing and expanding the capabilities of their perhaps initial occupational clinics into primary care and worksite primary care and wellness centers. Our organization offers a variety of educational programs, networking, benchmarking, purchasing support, vendor identification, advocacy services for those not only who are sponsors of worksite centers, but also for the industry itself. We are truly an organization representing the worksite center industry. So we have a number of major third-party service providers, hospitals, health systems, consultants, and others who make it possible for employers to offer this great benefit. Please visit our website at www.nawhc.org and join our LinkedIn groups, which have the current information about what's going on. Our next program is scheduled for October 26th and 27th in Hollywood, Florida. It's the 2023 On-Site Employee Health Clinics Conference. It's run and managed by BRI Network, but we'll be there, and members of NAWHC do get a discount. So encourage you to consider that if you've got the opportunity. It's always interesting to meet new people and new topics. For today, if you have questions, please use the chat or the Q&A box on the bottom of your screen or wherever you may have put it for this morning. We will take those questions afterwards. And we'll go around the table as well and ask everybody for any comments and experiences they might have or want to share. This is being recorded, and the recording and slides will be available to everyone who's on this program on the call, and will be posted at the NAWHC website for members subsequently. So with that, our speakers today are Caitlin Galen, Pharmacy Director of Clinical Pharmacy at Premise Health, and Barbara Flisch, founder of Principal AMP. So we're going to start out Caitlin's background. She, as I said, Director of Clinical Pharmacy for Premise Health. For those not familiar, Premise is one of the largest, if not the largest, worksite center vendor, having perhaps over 800 worksite centers covering, I think, about 11 million lives today around the US and the country. As clinical director, she's in charge of implementing and optimizing the pharmacy center clinical programming, as well as advancing initiatives to promote Premise's advanced primary care model. Prior to that, she was a pharmacy manager at a worksite pharmacy for a transportation employer, and she's been involved in the industry for quite a while. So with that, I'm Barbara Flisch, leads AMP, which is a consulting firm providing specialties, professional expertise to amplify business success. She's got over 15 years of experience in service sales and executive roles with a variety of organizations like Aetna, Definity Health, and Highmark. She also was a benefits consultant with Watson, Towers Watson, and served a number of large Fortune 100 clients. So with that, I'm going to turn it over to Caitlin. Caitlin? And let me stop my share so you could do yours, so just bear with me.
Thank you. I think it's showing that I'm in control now.
Why don't you try it first, and then
okay, yeah. So I'll
just go to the first slide. Yeah.
Great. All right. Well, thank you, okay. Larry, Diana, and oh,
hold on a second. Hold on. Hold on. Okay, now try it. There you go.
Okay. Good.
There you go. Yeah.
Great. All right. Well, thank you, Larry, Diana, and NAWHC for having me and Premise Health be a part of this webinar today. The title of my section is Pharmacotherapy for Obesity, and I'll be talking about anti-obesity medications and their place in weight management. So objectives for today: first, we want to understand why obesity is now diagnosed and treated as a chronic health condition. We'll highlight some tenets of lifestyle medicine, provide a general overview of currently available and pipeline anti-obesity medications, and describe policies, procedures, and resources that are needed to host a successful obesity management program. So starting with what is obesity. On this slide, we'll go into what makes up a diagnosis of obesity. Obesity is defined by the World Health Organization as abnormal or excessive fat accumulation that presents a risk to health. Evidence shows that obesity is a serious, chronic, and progressive condition that requires long-term medical management. In fact, in 2013, obesity was officially recognized as a disease. Prior to any member encounters, we as providers need to check our own bias around weight and make sure we manage members with obesity no different than members with other chronic diseases. To put together a diagnosis of overweight or obesity, it's important to consider both anthropometric measurements and the full clinical picture of the member. Using AACE and ACE's clinical guidelines for the medical management of obesity, they recommend an annual screening for BMI, as well as a waist circumference measurement for any member with a BMI less than 35. BMI is not a perfect tool. It's simply a formula that uses height and weight and not a specific biomarker and cannot be a standalone data point for diagnosis. The clinical components listed to the right are both potential complications of untreated obesity as well as risk factors for obesity. Members may present with obesity, a weight-related comorbidity, or both. BMI, waist circumference, and presence and or risk of weight-related comorbidities will stratify goals of a weight management treatment plan into primary, secondary, or tertiary prevention goals. The pathophysiology or causes of obesity are very complex, and they include many hardwired factors such as metabolism and genetics. However, these are not the only uncontrollable or at least hard to control considerations. For example, the environment in which a member lives can contribute to nutrition, physical activity, and stress levels. It isn't reasonable to expect a member to be able to completely shift their living environment to manage their obesity. The obesity system map on the right, I just included this on this slide just to drive home the point of the complexity of the obesity disease state. We do know that the brain regulates food intake. The hypothalamus is the main part or the main hub for all signals both into and out of the brain that triggers suppression or stimulation of appetite. Also, GI or gut hormones can independently act on digestion and absorption of nutrients by regulating gut motility and absorption. When there is a disruption in those signals, over time, this can lead to poor eating behaviors, which will eventually result in obesity. So why is it so hard to lose weight? Great question, right? Everyone has heard of the dreaded weight loss plateau, or if you're like me, you've personally experienced it. Weight loss typically plateaus around 6 to 9 months of steady weight loss interventions. More than 2/3 of patients who lose weight will gain 5 or more pounds back after a year. This is due to metabolic adaptation. When a person loses weight through calorie restriction, this may cause the body to react by slowing down the metabolism and altering the appetite regulating hormones, things you may have heard of like insulin or leptin, and GI peptides, things you may have heard of like glucagon-like peptide 1, GLP-1, and glucose-dependent insulinotropic polypeptide, which we'll call GIP. There might be an increase in hunger hormones and a decrease in satiety hormones. We need to balance these two mechanisms to control weight loss and prevent weight regain over time. Another reason for difficulty in losing weight and maintaining weight loss is due to barriers members experience to proper management. The graphic on the right-hand side is from the ACTION study, ACTION standing for Awareness, Care, and Treatment in Obesity Management Study. It investigated barriers to obesity management from the perspective of people with obesity, healthcare professionals, and employers. So look at those numbers and imagine if we were talking about another chronic condition such as type 2 diabetes or rheumatoid arthritis. Would it be acceptable to correctly diagnose just over half of those patients and only schedule a follow-up appointment for 1 in 4 of those same patients? So to summarize this slide, members with obesity have their own bodies and metabolisms often working against them while trying to lose weight, and the health system currently, collectively, is not providing the correct resources and approaches to maintaining weight loss. Weight loss, as most of us well know, has many positive health impacts, but most notably, they have positive impacts with our members that have weight-related comorbidities. I alluded to tertiary prevention goals earlier in this presentation and included those AACE/ACE guidelines to reference against evidence that has shown proven therapeutic benefits that was reported by the Business Group on Health. So thinking about type 2 diabetes as an example, per the guidelines, the tertiary prevention goal for a member that is also obese and has type 2 diabetes is to lose 5 to 15% of their baseline weight in order to do things like reduce their A1C, reduce the number or doses of glucose-lowering medication, and even possibly go into diabetes remission. This matches the results that we see on the right-hand side that shows A1C will decrease with as little as a 3% weight loss and continues to decrease all the way up through a 15% weight loss. Diabetes remission also matches at the higher end of those weight loss goals at 10% to greater than 15%. So employers are seeing the impact of obesity in a number of ways. Prevalence amongst their employee population, direct healthcare costs, costs due to lost productivity, and declining levels of health in their population. Obesity is not selective. More than 42% of US adults are obese, and no state has less than 20% of adults with obesity. That number is expected to hit approximately 50% by 2030. Direct healthcare costs are not the largest component of healthcare spend for employees, although $480 billion is nothing to brush off. However, if you look at the lost productivity costs, this is where employers are really getting stretched, spending approximately $2.60 on lost productivity for every dollar of direct healthcare costs. But the biggest financial impact to employers appears to be downstream costs from comorbidities attributed to obesity. Thinking about diabetes again, so if in an adult who is overweight, they are about 1.5 times more likely to develop diabetes versus an individual with a weight in the normal range. And that risk becomes about 3.5 times greater for an individual with obesity. I know the major focus for today is on anti-obesity medications, but I want to quickly highlight on the importance of looking at lifestyle medicine as an essential prescription for any member care plan concerning weight management. This slide highlights major differences in approach to weight management using conventional only versus lifestyle medicine approaches. Lifestyle medicine, to be effective, requires the provider to take a holistic view of their member and to focus care management on behavioral change. Behavioral changes may be best addressed or at least supplemented by other team members such as wellness coaches, dietitians, behavioral health specialists, and/or physical fitness experts. The most successful lifestyle medicine programs capitalize on utilization of an integrated, comprehensive patient care team. At Primus Health, we pride ourselves on utilizing lifestyle medicine in all of our wellness programming, including weight management. The American College of Lifestyle Medicine is an excellent resource. On the left, you can see there's 6 powerful interventions for improved health. In addition to standard diet and exercise interventions, member care plans should also include an assessment of quality of sleep, use of risky substances, stress levels, and connections to family, friends, and their community. So we just reviewed how behavioral change is important for weight loss, but also remember our previous point that many members with obesity have hardwired barriers to weight loss, where lifestyle medicine interventions alone won't be enough to treat their obesity. The next slides will provide an overview of currently available anti-obesity medications, which I'll call AOMs from here on out, as well as what's in the pipeline. While medication treatment for obesity management is all over the news today, it's important to note that this is not a new phenomenon. We've been using meds to treat obesity for close to 80 years. These historic AOMs that are still available today have become very inexpensive. The high cost of GLP-1s has some payers revisiting interest in these options. However, as you can see from the past being titled Approve and Remove, safety and efficacy on older medications has always been a concern. Amphetamine stimulants, also called anorexiants, have been used as appetite suppressants as as far back as 1947. The most popular historic approval with press and fanfare rivaling what we're seeing today was fen-phen, which is fenfluramine and phentermine in the 80s and 90s. However, due to a variety of reasons surrounding safety, efficacy, or both, such as with fen-phen, most of the meds that were used in the 20th century have now been withdrawn from the market by the FDA. Important to note, the FDA actually began to evolve their thought process for drug approvals for weight loss, along with the evolving science of obesity as a chronic condition. Over the past 25 years, they have shifted to requiring AOM studies for chronic use and looking at obesity as a chronic comorbid condition, which brings us to where we are today. We're now beginning to see the impact of these important changes in medication management of obesity with the dramatic rise of GLP-1 medications. While initially developed to treat diabetes, researchers found the additional benefit of weight loss, which was a very pleasant surprise compared to many traditional diabetes meds which cause weight gain. There are now several GLP-1 medications on the market today, but only 2 have FDA approval for obesity management. In this moment, we're seeing a time of transition as there will be a radical shift in expansion in this drug market over the next decade. Pharma doesn't have to hold separate trials to gain approval for weight loss if that loss is proven in original trials for a different chronic condition. It is likely that drugs already under development for conditions like diabetes, NASH, or cardiovascular health will seek approval for obesity management as well. Fortunately, based on historical norms, we will likely expect the increased competition to lead to lower net payer prices and better drug access. But on the flip side, we will also expect more utilization. So does GLP really stand for good luck payers? Hopefully, with correct utilization and comprehensive programming, it will not. We'll go into each AOM in a moment, but I wanted to highlight some of the key components of pharmacotherapy providers should consider when selecting an AOM. Most AOMs are now indicated for long-term use, but we do still have our historical anorexians and a medical device that do not have chronic use labeling. The picture towards the bottom gives a nice overview of how to assess cost versus efficacy in practice. Green coding would be considered ideal, and then you descend from there with yellow, then orange, and finally red. Semaglutide, also known as Wegovy for weight loss, is our poster GLP-1. It's far and away the most efficacious option, but if a member can't afford the higher cost option, or maybe they don't have more than a 5 to 10% weight loss goal, looking at Qsymia, Contrave, or even a short-term option could be a better choice in that situation. So as a reminder on anorexians, they work by suppressing appetite. Because they are stimulants, the best time to take these is before the first meal of the day. You need to think long and hard before prescribing these to members with any heart rate, cardiovascular, anxiety, or substance use disorders. Tolerance can develop quickly, such as within a few weeks of use. And if this happens, or it's not found to be effective after up to 12 weeks of use, it should be discontinued. Prescribing an anorexiant for more than 12 weeks would be considered off-label. These were all approved prior to the new FDA requirements for AOM development studies, but there is some evidence for longer-term use. Kaiser Permanente did an observational study looking at 14,000 users of phentermine and found that it was safe and effective long-term. The 144 patients who used phentermine continuously for 2 years were able to keep off 7% of their body weight without increasing risk of a cardiovascular event. Gelesis 100, brand named Plenity, works in a pretty interesting way. The capsules are considered a medical device that expands in the stomach to promote a sense of fullness. The hydrogel particles in the capsule expand by pooling in water, which is why it's recommended to take each dose with 16 ounces of water to mimic the structure and elasticity of raw vegetables. This results in the expanded particles occupying about 25% of the stomach. Some also remain in the small intestines to give a sense of fullness. In the large intestine, the particles will dissolve, they leave the body as waste, and the water is reabsorbed. The efficacy for Plenity is shown at 6 months, implying chronic use. It does not have that labeling, though, because of its classification as a medical device, not a medication. This also leads to complications with insurance billing. So currently, Plenity is only available through an online mail order pharmacy where the member would pay directly for it without insurance. Orlistat, which is available in OTC and prescription-only forms, works by preventing fat absorption in the stomach. It blocks about 1/3 of consumed fat, but has no effect on appetite. Side effects are infamous with orlistat and include fecal incontinence, flatulence with discharge, and frequent bowel movements. The less fat you eat, the lesser the severity of these side effects. So side effect avoidance is a great motivator for diet changes. Patients utilizing long-term may need vitamins A, D, E, and K supplementation because by blocking fat, orlistat also reduces absorption of fat-soluble vitamins. All medications should be taken at least 4 hours apart from orlistat, which can be very tricky since it's dosed 3 times per day. So probably not a great choice for a member on other chronic medications. Fusimia is a combination of phentermine, an anorexiant, and topiramate, an anti-epileptic, anti-seizure medication with a noted side effect of weight loss. Fusimia is the closest alternative right now to semaglutide in terms of efficacy, but also has a lot of potential barriers to use. Due to the link between topiramate and fetal oral clefts, women that are pregnant or trying to become pregnant should avoid this option. The topiramate can also disrupt stability of seizures in epileptics and or cause significant mood changes. Couple these warnings with the previously reviewed considerations for phentermine, and we end up with a limited eligible patient population compared to other options. Contraves combines 2 medications also, an opioid antagonist with an antidepressant. It's believed to work on 2 areas of the brain, the hypothalamus to reduce hunger, and the mesolimbic reward system to help control cravings. This same reward system manipulation also explains single ingredient bupropion's other labeled uses, such as depression under the brand name Wellbutrin and smoking cessation under the brand name Zyban. Bupropion is also the reason Contrave can't be used in members with a history of seizures, as there is evidence that it lowers the seizure threshold. And Contrave is not for everybody, as evidenced by the high discontinuation rate, but it could be a great option for a member that has issues with controlling their cravings and or is also looking to stop smoking alongside their weight loss goals. Saxenda, which I call the OG GLP for weight loss, stimulates GLP-1 receptors that makes us feel both increased satiety and fullness while decreasing appetite. The chemical liraglutide is also the active ingredient in Victoza, which is indicated for diabetes. Victoza is titrated up to 1.8 milligrams daily, whereas Saxenda is titrated up to 3 milligrams daily. Its pen design and daily use require a separate prescription for pen needles for safe administration. Ever since semaglutide hit the market, liraglutide has become less popular. However, semaglutide supply and cost issues have led to a resurgence in Saxenda demand, resulting in it being in short supply starting just a few months ago in July of 2023. Liraglutide has the same safety profiles as GLP-1s as a class, and I'll go into this a little more in depth on the next slide. The semaglutide has the same mechanism of action as liraglutide, but it is more efficacious and more appealing due to its longer half-life, only requiring once-weekly injections instead of once-daily dosing. Semaglutide has 2 diabetic counterparts, Ozempic, a once-weekly injection that can be titrated to 2 milligrams weekly, and Rybelsus, a once-daily oral option titrated to 7 milligrams or 14 milligrams daily. The Wegovy pen device already has the needle attached, adding to its appeal. The member never has to see the needle, and an additional prescription for pen needles is not needed. So here's where I'm going to go into a little more depth about GLP-1 class contraindications, warnings, and side effects. Probably a lot of you guys have seen these are highlighting the news stories recently. So let's work our way through these. Screening and monitoring of thyroid levels cannot be overlooked, and there is a black box warning against use in anyone with a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia type 2. Nausea, vomiting, diarrhea, and the more serious side effects, ileus and intestinal blockage side effects, can be root cause to the way GLP-1s slow the movements of the GI tract. Counseling to eat smaller meals throughout the day may help with the nausea and vomiting. There are many reports of members being prescribed scheduled long-term regimens of antiemetics, such as ondansetron and or antidiarrheals. Short-term use of these can help with tolerability for sure, but I would advise against long-term use as it may be hiding signs of the more serious GI side effects. I don't have this included in the slide, but extra attention should also be paid to anyone on a GLP-1 that's also on insulin or a sulfonylurea. GLP-1s alone can reduce circulating blood sugar, and that you couple that with the reduced blood sugar benefits of weight loss. When you have a member that's also on the insulin or sulfonylurea, there becomes a much higher risk of hypoglycemia. The blood sugar monitoring is imperative, and the provider should reduce doses of either of those to avoid hypoglycemia. Finally, there are also some reports circulating about increased rates of depression and suicidal ideation with GLP-1 use. The FDA is currently monitoring those reports, but until more is known, it is important to perform a mental health screening prior to initiation of a GLP-1, as well as regular screening throughout therapy. So it wouldn't be a true review of GLP-1s without a discussion on their significant rise in utilization, as well as the expense associated with them. We have seen an enormous increase in GLP-1 prescriptions written in the last few years, over a 2,000% increase since 2019. And it seems like every news outlet, TikTok account, Instagram, and magazine is hyping up these drugs as miracle weight loss solutions. Many vendor solutions are responding to these demands by pitching easy access to these drugs to both employers and individuals. Demand is so high that consumers may select a vendor, not realizing or not caring that these drugs may be prescribed without an accurate assessment of health history, and the medication itself might be off-label, compounded, or in the worst cases, counterfeit. So now we got to also think about the cost. GLP-1 expense is top of mind for employers. Per member per month spend on these drugs has already risen almost 500% in just the past 4 years, and 2,000% for the drugs approved for weight loss. The graph in the middle shows national utilization of 4 GLP-1 medications for non-diabetic adults. So it's important to note here that only 1 in 4 of these medications, Wegovy, is actually approved for obesity management. So due to excessive demand, supply chain challenges, and higher member costs for Wegovy, we saw a large spike in off-label prescribing and use of other GLP-1 medications. This is quite the headache for employers trying to get a picture of which populations are truly driving spend in their GLP-1 category. Hopefully, as market conditions normalize, supply is restored, and new drugs are approved, we should see further reduction in off-label prescribing, allowing for better transparency. We also, though, have to expect increased utilization and spend in the weight loss category, which is why I've included some tips for controlling costs both for members and employers. A lot of these strategies are similar amongst the two. Researching and understanding an employer's PBM is going to be really helpful for member costs if you know which options are covered and preferred, and what clinical criteria are required for those for that coverage. On the employer side, this is going to help you base what the employer is looking for in terms of utilization guardrails. You can also utilize manufacturer copay assistance cards to drive down costs for members and employers. And sometimes for employers, you can couple that with copay maximizer programs that are offered by other vendor partners. Engaging with pharmacy partners is another one that can be a member and employer savings opportunity. Pharmacy partners are important for members because they ensure that they have access to the medication and that they're continuing appropriate care. They also have great resources and great knowledge on adherence to medications, which will help prevent drug waste to the employer. The final point for members is that we really want to encourage them to avoid risky practices. So we really want to have them avoid non-FDA approved compounded products. They're not really sure what they're getting, and the dosing can be very complicated. We also want to make sure that they don't have anyone that's coaching them to get a diabetes diagnosis when they have maybe a lesser metabolic comorbidity that does not require that diagnosis. To round out the employer side, one thing that we found that's really helpful, one, is to make sure that anybody that's running a management program for you is very clear that they're not doing any manipulations of the insurance coverage. They're prescribing on label. They're not prescribing unnecessary medications to obtain coverage, such as reports of prescribing metformin for members so that GLP-1s will go through as the metformin indicates that that person is a diabetic. So I kind of lump that all up as we're making sure we're also submitting prior authorizations with integrity. An interesting way to kind of think about savings too is to make sure that anytime you have a diabetic, that you prescribe them a GLP-1 that's indicated for diabetes, even if the target is just weight loss and not necessarily reducing A1C. Rebates and pricing for the diabetic indicated GLP-1s are often better on the back end for employers. And then consider non-GLP-1 anti-obesity medications For lower risk members, one thing that we'd heard from employers is they want to provide coverage for AOMs, but they want a better way to stratify the highest cost for the highest value. So if you have a member that has a lower BMI or no major comorbidities and are eligible for a non-GLP, it's a good consideration. So what's in the pipeline? Pipeline research and development is going to continue to focus on the hormones that affect appetite, satiety, and digestion and energy expenditure. Double and triple hormone agonists are showing results that mirror bariatric surgery, as hormones like GIP and glucagon increase caloric burn where GLP-1 does not. Some hormone targets don't slow gastric motility, such as leptin, which provides potential options for members that cannot tolerate the GI side effects of GLP-1 agonists. R&D is also spending time on optimizing dosage form choices for members that may prefer an oral option to an injection. You can see 2 of the 6 medications in late-stage development are daily oral options. One thing that is consistent across all of these pipeline drugs is their efficacy. They're all matching, if not greatly exceeding, the currently available anti-obesity meds. So understanding pharmacotherapy for obesity is important, but putting that knowledge into action requires a strong program framework. I'll end this presentation with key components needed to run a successful weight management program. Any weight management program should be grounded in clinical excellence. Premise Health prides itself on being an evidence-based organization. On the left side of this slide, you will see the standards of care for obesity by the Obesity Medicine Association, which is the framework for Premise's Beyond Weight program. On the right, you see an example curriculum used at Premise Health for lifestyle medicine, also as part of our Beyond Weight program. This learning series is sent to a member enrolled in the program each month and is ordered in a purposeful way to allow for maximum impact. A 2022 Harvard study found that 69% of people with obesity who are interested in treatment with GLP-1s would prefer to work with a primary care provider. The study also found that care provided by a PCP leads to better long-term weight loss results. Why is that? Managing obesity is complicated, and it takes providers with expanded training to engage, motivate, and treat members. By focusing on obesity as a disease, PCPs implement standards of care under the same framework as other conditions, using a care team approach that focuses on the whole person. A program incorporating anti-obesity medications should have some guardrails and guiding principles to help providers appropriately utilize pharmacotherapy. First, pharmacotherapy should only augment lifestyle efforts, not replace them. If a member is unwilling or unable to make lifestyle changes or adhere to lifestyle medicine recommendations, pharmacotherapy will not be a good substitute. 2, member education is paramount. Time should be taken prior to initiating any anti-obesity medication to go over how and or why a medication works to increase their weight loss and what to expect in terms of side effects and monitoring requirements. They should also be educated that a medication may not work for them or cannot be tolerated, and that is okay. It does not make them or their weight loss efforts a failure. There are guidelines on discontinuing and switching medications for this very reason. And 3, we can look at algorithms, charts, flow sheets, and protocols for days, like the one shown on the right-hand side of this slide. But each member is different, and there is no one cheat sheet that will have the correct answer for everybody. Pharmacotherapy has to be tailored to each individual. A member's experience with your weight management program doesn't end when they walk out of the health center. What happens after the diagnosis, the coaching, and the prescribing is just as important to a successful care plan. Unfortunately, many members are left to navigate a pharmacy experience that can be confusing and frustrating. Member experience and satisfaction with the community pharmacies continue to suffer, and there is little to no coordination between a member's medical and pharmacy teams. This leads to delays in treatment, unnecessary expense, and poor adherence. Incorporating pharmacy services provides a tremendous opportunity to add value to your members and clients. Once a diagnosis and prescription need is identified, pharmacy can focus on access to, adherence to, and affordability of the AOM. To accelerate access, integrating pharmacy teams can directly coordinate with the primary care team to streamline the prior authorization process with PBM. This leads to a lot better member experience with reduced frustration and increased communication. Additionally, pharmacy teams can proactively support members navigating drug shortages, manufacturer coupon programs, and plan design to get the best medication accessibility once they've met that appropriate eligibility criteria. However, simply having a drug in one's possession does not solve anything. If it did, we would have dramatically less chronic disease in our country today. Less than 50% of the US population is adherent to medications, meaning we shouldn't assume members are using the meds they or your client are paying for. Pharmacists can provide proactive education, adherence coaching, ongoing outreach, and follow-up support, all driven by member adherence data to ensure that members are actually using the medications they receive. Finally, every successful program needs to define what success looks like. It should be determined from the start what outcomes will be valuable to track and how can these same outcomes be effectively tracked. Often successful programs can show both primary and secondary benefits. Primary benefits include our typical clinical outcomes, but secondary benefits can include things like smoking cessation, member empowerment, improved productivity, increased perceived quality of life, behavioral health, and sleep benefits. Sharing results with employers should include a mix of quantitative and qualitative data. Numbers are great, but member experience stories bring life to the true impact of your weight management program on their employees. For instance, which part of this slide inspires you? The 16% weight loss data point, or Linda, real patient, not real name, her weight loss journey. My key takeaways are here, and happy to pass this off to Barb.
Great. Thank you so much, Caitlin. Appreciate it very much. So let's turn it over to Barb. Barb, please share your screen and let's make sure you can get started.
Fantastic. I will do that. And while I am getting ready to share my screen, I have to say, Caitlin, thank you so much. So many of the points that you make are excellent and in line very much with what I'm going to say. So thank you for that. And thank you everyone for being here. I'm Barb Flitch, as Larry introduced me earlier. Actually, I've been in the benefits industry for about 35 years in kind of, as he said, all sorts of roles. But what I want to share with you today is a very personal journey. It's filled with shame, anxiety, regret, and hope. And I hope that it inspires you to think about how you're approaching this in your clinics and your businesses. We started studying biology when I was in 5th grade. And the day the teacher taught us about body types was the first time I ever felt public shame about mine. As she flashed the images for the 3 body types onto the wall, she asked 3 of us to come and stand where we thought we belonged. I went and stood in front of the middle one, and she looked at me and said, "Oh, no, dear." Put her hands on my shoulders and moved me over in front of the big kid and said, "You belong here." So as you might imagine, my fate was sealed in that class. Lots of bullying and all kinds of other stuff went on. They seized on it and never let go of it. So after a consultation with our pediatrician, I started my first diet. And that day, the seeds were planted of what would eventually become what we now call food noise in my head. For the next 50 years, from the moment that I woke until my last conscious thought, some part of my brain would be focused on food. In many cases, I was unaware of it. That is food noise. And if you have no idea what I'm talking about, good for you. If you do know, then even though I can't see you, I see you. We know that the development of obesity relies in some part on genes. So at the age of 47, I did a genetic panel and it highlighted my enhanced risk for not only developing obesity and diabetes, type 2 diabetes, but a host of other related conditions like osteoarthritis and atrial fib. George Bray, an obesity researcher, said it really well. Genes load the gun, but environment pulls the trigger. In middle school and high school, the social aggression increased, and it was made clear to me daily that my size was solely due to my own moral failure. The food noise grew more insistent. The assaults by adults with good intentions continued as well. Like the high school choir choreographer who told me in front of a room full of peers that I could never make swing choir because no one would want to watch me dance around on stage like a cow. The food noise grew louder and began to take up more space in my brain. By the time I got to college, I had reached my highest weight ever, 186 pounds. Fun fact, in these pictures, my parents are the same age that I am now. So just a plug for what a little occasional facial massage will do for you. My dad was now living with type 2 diabetes, managed with oral medications. During college, despite pursuing a food-based major in hotel and restaurant management, I did lose weight and I had help. My first serious boyfriend was a bodybuilder with a Pygmalion-like commitment to my weight loss and transformation, and it worked. I lost 50 pounds. Eventually, however, it became a psychologically abusive relationship focused on maintaining my weight loss. But what was obvious to everyone else was oblivious to me. At her wit's end, my mother sat me down at one point and told me, if you come home and tell me that you're engaged to that man, I'm going to take you out in the garage, I'm going to shoot you, and then I'm going to shoot myself. It took another 6 months for me to convince myself that I deserved something better and to leave him and the extremely unhealthy workout habit that I developed behind. My mama loved me. But I was alone again. It was just me and the food noise. And by 1984, with some vigilance and some really destructive habits like smoking, I thought I'd gotten it under control. Then I met this guy who's stuck with me for nearly 40 years since. We promised to be true to each other in sickness and in health, but maybe we should have said through thick and through thin. 5 years later, I was on my way in my career and benefits and ready for the next phase of life. In 1993, I got pregnant. I gained about 50 pounds, and after the birth of our daughter, I couldn't shake the last 15. In January of 1996, I quit smoking cold turkey. 35 pounds came on fast and stubbornly refused to leave me. So the 50 pounds that I'd lost in college was back. I was now working in crazy startup land, spending weeks and months on the road. I squashed the food noise, instead eating my stress. There were real consequences for my career. I'd always been a high performer, so was shocked when my boss told me, you'll never make it in sales unless you lose weight. I'd been told I couldn't be promoted unless I lost weight. One time at a dinner party at his home with my family, after repeated pointed jabs at my size, his wife looked at my 9-year-old daughter and told her that she should hope that she got her father's genes and not mine. The insidious food noise expanded, and I was certain now that my failure was impacting our daughter. In 2009, I hired a health coach and personal trainer, working with her 3 times a week for 9 months to prepare for our first ever trip to Europe. When that didn't yield the results I'd been told it should, because of course, eating less and moving more should do it for you, I decided to cheat and invested $3,500 in a medically supervised liquid diet fasting program that included group therapy, regular biometric screenings, and lab tests. And it worked great. I lost that 50 pounds again. But 10 days before our trip, I ended up having emergency surgery to have my gallbladder removed, which was a known side effect of my rapid weight loss. My body healed, the thousands of dollars in medical expenses were paid, and the drumbeat of food noise marched steadily on. Over the next couple of years, I became a caregiver for my mom. We almost lost our daughter in a hospital-acquired infection. She graduated from high school and moved across the country to college, and I switched jobs, commuting weekly out of state. Most people that I looked at and interacted with during this time would have never figured the turmoil that my body was in because I looked good. I could no longer exercise without breaking out in head-to-toe hives that at one point were so bad, I ended up in the emergency room, and after 3 doses of epinephrine, the clinicians looked at me and said, there's nothing more we can do for you at this point. We may have to transport you rather than lose you. The steroid cream that I was eventually given to treat it was $200 a tube. The wheels spun and the food noise hummed on. Big surprise, but by 2012, I was back at 186. I sat in rooms where my colleagues and clients decried the moral failures that led all these people to be obese and diabetic. Why can't they just eat what they're supposed to and move more? Everyone can find 20 minutes a day to move. The stress of life piled up. I packed on more pounds, approaching the 200 mark. In 2013, I was officially diagnosed with type 2 diabetes, not by my doctor, but after I applied for life insurance. Filled with self-loathing at my failure to avoid this outcome, I resigned to live with the fate that I believed was solely of my own making. That same year, obesity was classified as a chronic disease which could be medically treated. No one had ever told me there might be factors at work beyond my control. Many of the sweetest moments in my life have been filtered through consciousness about how I looked. You can call that vanity, but it's so much more than that. Seeing pictures of myself in these big moments is tough because these are the times when my lack of willpower was on full display to everyone. I can't get those moments back. I remember shopping for a dress for our daughter's wedding. I described it to some friends as utterly demoralizing. It was almost impossible to conceal the deep shame that I felt as tiny women using enormous clips and elastic bands did their best running around the dressing room trying to approximate what the sample size dress would look like on my decidedly not sample size body. And because I was so consumed with my own humiliation, I missed creating the experience, the once in a lifetime experience that I dreamed of giving my daughter in that moment. This is not vanity. The costs of dressing a large body can play a big part in the mental and financial well-being challenges that come with obesity. As my A1C crept over 7 in January of 2020, my doctor convinced me to add Farxiga to my metformin. I'd resisted these expensive meds for a host of reasons, not the least of which is that I'm a benefits professional and I know what this stuff costs. But at my highest ever weight of 207, I was more afraid of insulin dependence than of anything else. I was off the road for the first time in 20 years when the pandemic happened, and I had complete control over my food and movement. There wasn't anything to do but walk outside. So I had no more excuses. I lost 23 pounds that year, but the food noise persisted. I managed to keep it off. I was down over 10% of my body weight, and based on Caitlin's graphs, I should have been doing great. But my A1C was still at 6.8. My doctor suggested I try a semaglutide in late 2021. Again, I resisted taking the easy path. I didn't think I deserved a simple answer. Sorry, late 2020. Then in early 2022, our daughter announced that she was pregnant. Angst-ridden about my future as the grandma who could get on the floor and play with the kids. I managed to lose another 11 pounds, but I was stuck. I never put it together that my body was fighting to put the weight back on with an intensity that exceeded my drive to keep it off. In early September of 2021, I told my doctor I was ready to try the new med. She prescribed Ozempic. The hype around the drug doesn't help patients overcome with this guilt. When I hear somebody say it's the easy way out, I know that they have no idea what they're talking about. The results are real, but so are the side effects, ranging from various forms of GI distress to things that we don't hear as much about, like brain fog and crippling fatigue as you titrate up. This is one of the self-limiting characteristics of these meds. Not everyone who needs them or could benefit can tolerate them. I'm one of the lucky ones. When people I haven't seen for a while ask me what happened, I tell them I won the diabetes lottery. I got the drugs and they worked, and they continue to work. Today, I'm down a full 30% of my body weight from the beginning of 2020, and my vital biometrics are all within healthy ranges. I was able to stop a $600 a month medication just this past June, and I have good reason to believe that I've added a number of high-quality years to my life. Because I've lived my entire life vigilant, I know what to do. I will echo what Caitlin said. Check your own bias. Don't assume because someone is still overweight, they haven't tried anything. I hear this all the time. I don't need behavior change. I know what behaviors I need to engage in. I need support doing them. Don't assume because someone is big, they're dumb or they're uneducated. We know, we've been told our whole lives. Some people, it just does not work. I deeply regrets the moment that I lived through shame instead of joy that I can't reclaim for myself or for my family. I'm objectively curious about where my career would be today had I gotten this medication sooner. I wonder how my health might be if I had had this medication before I developed diabetes. I do think about how much has been spent dealing with the medical fallout along this journey. But the biggest change is that the food noise is gone. This medication, this miracle, fixed my brain. The noise that's been circulating in my head since I was a little girl has been silenced. And so has the profound guilt, shame, and sadness that's been the soundtrack in the background my entire life. It feels as if my brain's been Marie Kondoed, if you know that reference. This is what happens when you fix the software so the machine runs properly. Objectively, I've never been more productive. People who've known me for decades say that they've never seen this version of me. I can't change the past, but what I can do is share the story with you. And I'm not unique or special. This is the story of so many of your family members, your friends, your coworkers, plan members, and patients. But I'm also a benefits professional. And so I want to talk about changing the game. Employers, you know, you're tasked with tremendous pressure to solve for many dimensions of employee well-being. And you've invested in mental health solutions, and you've invested in physical well-being solutions, and you're investing in on-site clinics. But do you know that this affects disproportionately people of color and women? If you care at all about diversity and inclusion, this is a big deal. Health equity, right? You know, again, Caitlin, great point. You can't assume that someone can change their external environment simply to meet their weight loss goals. What other programs as an employer can you invest in that potentially impact 40% of your population, even those people who aren't going to potentially get the meds, right? The outcome is what they're really after. The medication is just a path for that. And as clinicians, I can tell you, watching this and watching, because I talk to a lot of people about this who come to me and they lower their voice and they say, yeah, I started on it in January, or I really want to try it, but it just seems so wrong. You know, this is the new antidepressant, right? But if we don't talk about it, we're never going to find the right answer or the right balance. So trained, compassionate listening, the kind of education that Caitlin's delivering is so important. Expert, clinically founded prescribing, what you just saw. I mean, I was so happy with Caitlin's presentation because it aligns so well with my message here, right? Vigilant monitoring. I have friends that have had to have emergency surgery and spent 10 days in the hospital because even though they went back to their primary care and their endocrinologists complaining of side effects, their symptoms were diminished and discarded. And so they ended up in emergency situations that ended up being life-threatening. 10 days in an ICU is a lot more expensive than this drug. And your corporate clients, for those of you in the clinic, first of all, they need you to care for their members. That's the biggest thing they're asking you to do. Exactly with what Caitlin talked about, alignment with plan protocols. Make sure you understand what those are before you engage in this and have a holistic approach to it. And I couldn't agree more about the data, right? It's one thing to have the claims and diagnosis codes and procedure codes and medication codes. It's something else entirely to talk to somebody about the dramatic shift and life-changing effect that this is having on them. Moving more, feeling better about moving, being able to sleep again, being able to think clearly again. And honestly, the idea that there's so much more capacity to be productive because some part of my brain is not focused on something that I don't want to focus on is incredible. And you are on the front lines of being able to help people accomplish that change in a responsible way. So thank you for being here today. Thank you for listening to the story. I sincerely appreciate it. And I will turn it back to Larry.
Great. Thanks so much.
If I can get
So
this.
at this time, what we'd like to do is to go around the table and see if people have questions for Caitlin and for Barbara. So let me just start out with Debbie Follett. Debbie, make sure I let you to talk. Any comments or questions, Debbie? No? Okay. Shelley? Shelley, any comments or questions? Okay.
Nope. Can you hear me?
Yeah, go ahead.
Nope, I don't. I just want to thank you. It was very informative, and I really appreciate Caitlin, your facts and presentation, and Barb, I appreciate your story. So thank you very much.
Thank you. Justin, comments or questions? Oh, okay. Kathleen, comments or questions?
This is Catherine. Sorry, I think you're referring to me, but
Yes.
I just wanted to thank you all for sharing today. Very compelling story. And I think you're right, Barbara, that so many people are experiencing very similar things to you. I am in the world of managing obesity myself from a programmatic perspective. And so I appreciate you sharing all of the different facets of it. It's not just behavior change. It's not just medication. It's not just one thing. It's such a multifaceted issue that we need to deal with in that way. So your story certainly is supporting my efforts and what I'm doing as well. So thank you for sharing.
Thank you. Brandon, comments or questions?
Yeah, I just want to say thank you to the presenters, and I agree. I really liked the holistic approach. So thank you very much.
Kevin, comments or questions?
Yeah, no questions, but thank you very much. It was very helpful.
Okay. Amira, any comments or questions?
No comments and no questions. Thank you so much.
Okay. Amanda, any comments or questions?
No, thank you both.
All right. Let me just go through some else. Debbie, any comments or questions? No. Okay. Justin, any comments or questions? Okay. Michael, any comments or questions?
The presentation today. Enjoyed hearing from the speakers. Thank you.
Thank you. Felicia, any comments or questions?
Hi, just wanted to say that I agree, echo the sentiment so far. Very informative. Really appreciate the facts, the statistics, and the personal story itself. Well done. Thank you. Thank you for this.
Sure. And Ryan, any comments or questions? Okay. Well, I have a last question that came in here. Caitlin, how do you handle the relationship with the PBM being as a worksite center? You don't keep these drugs typically at the center. And so it's prescribed. Well, is it prescribed by the doctor and nurse there, or do you refer out to a specialist? And then obtaining the drugs, does it come from do you order it from the PBM, or do you have your own supply? How does that work?
Yeah, so there's kind of two kind of major structures to somebody that's contracted with Premise Health. One where they have a health center that does not have an attached integrated pharmacy. And for those, they will go through the process of enrolling the member in the program, doing the screenings and evaluations, and if an AOM is recommended, they prescribe out to a standard community pharmacy or mail order pharmacy of that member's choice. So in that, the relationship with the PBM is really going to be kind of twofold. One, to get information to help them guide appropriate prescribing choices that will be accessible to the member, and understanding clinical criteria ahead of time. We actually had a site that reached out and they were saying, well, we're spending a lot of time on these prior authorizations and they're not going through. And the first thing was, well, why don't you find out what the clinical criteria is? And if you know that ahead of time, then you can say right off the bat, okay, I'm not going to do this prior authorization. It's not going to go through. This doesn't match what they need, or maybe this drug is a step therapy drug or a non-formulary, but another one would be covered, and that would be saving you a lot of time. So there's a lot of that, and then the other side. Lost my train of thought on what the other part of that was. Oh, but same thing. So once you get that clinical criteria, then making sure that you're aligning with that, if not being a little more stringent. You never want to be less stringent, I feel like, than what the PBM is putting out. That just doesn't align the goals for the employer. Now, with an on-site pharmacy, those are contracted out through our pharmacy partner, and those pharmacies are just kind of the same structure. The health center provider will prescribe, and they will send to that on-site pharmacy, who then usually has a pretty good relationship with the clients or the employer's PBM contacts. For instance, when I was at my site, they utilized Optum, and I had 3 people on that account that I could reach out to and ask questions. So you become formulary experts in that regard, which is really helpful for managing access and appropriate utilization. And also the same thing, right? They have the education and they know what is and isn't going to be covered. And a lot of times we have insight into how the manufacturer can assist with cost and access as well. So for instance, with Novo Nordisk, they have those copay assistance cards that can be a really nice saver for the employer and the patient or the member, provided right up there as a benefit from that manufacturer.
Okay, thank you. All right, so before we close again, I'll open the door. Everybody's allowed to speak. I took off all the muting. Any last questions from anybody in the audience? If not, I want to thank Barbara and Caitlin for their participation in this, taking the time out. Barbara for sharing your story and direction, and Caitlin for giving us guidance and great information. As I said, this program has been recorded, and those who are attending will receive a link for the recording and to the slides. It will be posted for NAWHC members on our website. So look forward to hopefully seeing you at a future program. If you have any questions about NAWHC or this topic, feel free to contact me directly at lboris@nawhc.org. With that, everybody have a great weekend. Thanks again. Bye-bye.
Thank you, Larry.